From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Welcome to this podcast from JAMA Cardiology. This is Bob Bonow speaking. I'm professor of medicine at Northwestern University and editor-in-chief of JAMA Cardiology. Today we'll be discussing a very interesting study that we're publishing regarding cardio-oncology and the management of patients with pre-existing heart failure. I'm delighted to be speaking today with two experts in this field. First is Dr. Jenica Upshaw, who is associate professor at Tufts Medical Center and director of the cardio-oncology program there. Welcome, Jenica.
Thank you so much for the opportunity. I'm really delighted to publish our study in JAMA Cardiology and to be able to talk with you and Dr. Barac.
Well, thank you. And also joining us is Dr. Barac, who is a professor of medicine at Georgetown University and holder of the Daniela Chair, and also director of the cardio-oncology program at Innova Heart and Vascular Institute. Welcome, Anna.
Truly delighted to be here. Could not be happier to discuss this study with you and Jenica.
So this is an important topic because so many patients of advanced age may have heart failure when a diagnosis of cancer is made, and that may limit some of the therapeutic options, and that could also influence outcomes. Dr. Upshaw is reporting a very important study involving patients with diffuse B-cell lymphoma who have a pre-existing diagnosis of heart failure, based on data she's derived from the SEER Cancer Registry. Dr. Upshaw, first, let's help our readers understand what's involved in the SEER Cancer Registry and how that registry itself has been developed over the years.
Great, thank you. Yeah, the SEER Registry is a system of population-based cancer registries that captures about 25% of the U.S. population and consists of 13 different registries with detailed capture of cancer diagnoses and initial treatment. And then linkage with Medicare allows us to follow longitudinally patients who are 65 and older, who then to follow outcomes and subsequent treatment. As well, cause of death is adjudicated by the cancer registry. So it's a really fantastic resource just to understand on a population-based level cancer care, delivery, and outcomes in the United States.
Terrific. And of course, most of our readers may not be experts as you and Dr. Barac are in this field, but we're interested in excellent studies such as yours in cardio-oncology. The SEER Cancer Registry is Surveillance, Epidemiology, and Results, and the abbreviation is SEER. And this really is an excellent database for future studies. Okay, now based upon that database, Jenica, tell us a little more about the study that you did in these patients with diffuse large B-cell lymphoma.
Yeah, thank you. This really came out of my clinical work where I was seeing patients with cardiomyopathy or multiple cardiac risk factors who were diagnosed with aggressive lymphomas, who are really best treated. Still, the standard of care is a doxorubicin or anthracycline-based chemotherapy, which could cause heart failure or worsening heart failure, and really uncertainty about how we should manage these patients and whether it's safe to give them standard of care therapy. And I was curious to see how common this problem was and also how it was being treated throughout the country. So we designed this study looking at patients with diffuse large B-cell lymphoma. And we chose that type of lymphoma because it's very common. And about half of patients with newly diagnosed diffuse large B-cell lymphoma are 65 and older at the time of diagnosis. And we looked in the SEER Medicare registry from 2000 to 2015, designing the study to require 1 year of Medicare coverage in the year prior so that we could have a good understanding about cardiovascular comorbidities. And heart failure was diagnosed using an algorithm that's been validated using ICD codes, so defining one inpatient discharge diagnosis or at least 2 outpatient diagnoses to try to improve the specificity of that diagnosis, but based on ICD codes. And then we looked at patients with and without pre-existing heart failure at the time of their diffuse large B-cell lymphoma to look at how they were treated, whether they received doxorubicin or anthracycline-based chemotherapy, whether cardioprotective strategies that really have a lot of evidence in other cancer populations, such as in metastatic breast cancer, such as dexrazoxane or liposomal doxorubicin, which can reduce the risk of heart failure when in the setting of anthracycline use, whether those were used, and also the associations with cause-specific mortality. So looking at the association between pre-existing heart failure and lymphoma mortality and cardiovascular mortality.
So I'm a general cardiologist, and I have the luxury of referring patients of mine with cancer to cancer specialists and also to excellent cardio-oncology experts as well. But I take it that anthracyclines are the go-to agent for patients with diffuse large B-cell lymphoma. So those are the agents of choice.
Correct. Yeah, they are associated with the best lymphoma outcomes in terms of progression-free survival, induction of remission, and lymphoma mortality. So, with diffuse large B-cell lymphoma, the R-CHOP regimen, which includes doxorubicin, is standard of care. And there are other regimens that can be considered, but they have less lymphoma control and induction of remission, worse lymphoma mortality. So, the same is true for Hodgkin's lymphoma and some other aggressive lymphomas where anthracycline-based regimens are really preferred. And this is different than breast cancer or other types of cancers. It depends on the cancer characteristics, but where there are non-anthracycline regimens that can be close to equivalent.
Okay. And we're certainly well aware of the cardiotoxic effects of anthracyclines, which kind of gets to the heat of your database here. So tell us what you found then in these patients with pre-existing heart failure compared to those without pre-existing heart failure with this disease.
Yeah, so we found that pre-existing heart failure was quite common, seen in 13.9% of the population at the time of their lymphoma diagnosis had a prior diagnosis of cardiomyopathy or heart failure because we were using ICD codes. And that pre-existing heart failure was associated with a lower odds of treatment with anthracycline-based chemotherapy with an odds ratio of 0.55. So patients with pre-existing heart failure were less likely to receive R-CHOP or anthracycline-based chemotherapy. And that was about 25% of patients with pre-existing heart failure received anthracyclines versus 51% of those without pre-existing heart failure. And we found, somewhat surprising to me, these infusional cardioprotective strategies, which I mentioned, dexrazoxane, liposomal doxorubicin, which do have evidence in other cancer populations. They were not used commonly at all. About 7% of the patients with pre-existing heart failure received dexrazoxane or liposomal doxorubicin, and about 3% in those without pre-existing heart failure. So not used commonly. And then we found that pre-existing heart failure was associated with higher lymphoma mortality. And after adjusting for other comorbidities, it was still significantly associated with increased lymphoma mortality and quite high lymphoma mortality of 42% at 1 year, lymphoma mortality in patients with pre-existing heart failure compared to 30% in those without pre-existing heart failure. And not surprisingly, patients with pre-existing heart failure had higher cardiovascular mortality compared to those without heart failure, but still most of these patients were dying of lymphoma and not of cardiovascular causes.
Yes, I was really struck by these data about the higher lymphoma-related mortality in these patients. So I think these are important messages for all of us to recognize the risks of these individuals with treatment, but even worse, the risk of these patients without treatment. Let's bring in Dr. Barac then. You've written a very excellent editorial on this manuscript from Dr. Upshaw. And what are some take-home messages from you regarding these findings?
This study addresses what every cardiologist seeing these patients can see in the clinic. And I mentioned that in the editorial. If we look into the numerous now consensus statement guidelines that are out there, they're mostly focused on prevention and documenting cardiovascular side effects that we have known for years in case of anthracyclines on what happens. As a matter of fact, the Sierra database with the Medicare linkage has been used a number of times to show increased risk of heart failure down the road when anthracyclines are used. However, if we go back to that clinic when the patient comes and is being referred for existing heart failure or cardiomyopathy, it could be stage B heart failure, and has a diagnosis of lymphoma, that conversation between a cardiologist and oncologist needs to be focused about the benefit and risk. And the ASCO guideline nicely states that anthracycline should be avoided if established alternatives exist that would not compromise cancer-specific outcomes. Well, that's the enormous gap of data that we don't have, and I think that Dr. Upshaw's study is starting to unreveal. There's a huge paucity of studies that look at both outcomes. So what is the risk of lymphoma-related mortality? What is the risk of cardiovascular mortality? And once we understand that, we can start pushing forward the studies that would push for inclusion of these patients into the prospective studies to understand, is there a less toxic treatment? Could we, in the era where we are so good in treating heart failure, would it still be reasonable to use anthracycline and address the heart failure? Granted, it's not only cardiovascular mortality is not nicely shown, but I think it's just really emphasized the importance of studying outcomes because they're both relevant to the patient, right? We want the patient alive and healthy, free of lymphoma and free of advanced heart failure. So I was thrilled to put that forward. I think it really brings, none of our statements cannot address this point because there is such a paucity of data.
Yeah, thanks. Though it is striking in this population, in this database, we're seeing that the deaths from lymphoma were 3 to 4 times the deaths from heart disease. And so really this balance between the risk and benefit of anthracyclines in this population really is something that we need to focus on. Now, Jenica, your database is not granular enough to tell us whether these were patients with reduced ejection fraction or patients with preserved ejection fraction. Is there any way to unravel, which patients might be better candidates for anthracycline therapy versus those who are not?
Yeah, that's the main limitation of the study is that we did not have LVF data or symptom data or biomarkers such as natriuretic peptides. And so really understanding which patients we can safely treat with anthracyclines, with cardioprotective strategies, with maximal guideline-directed medical therapy. I think that that's where I would like to go with research in the future. And I think really characterizing the stage of heart failure and understanding which patients can be safely treated in close collaboration between oncology and cardiology, and which patients really that the heart failure risk or the cardiovascular risk is too great. I think we need further studies, and I think we need a combination of excellent studies like Dr. Barac's Safe Heart study in the HER2 positive breast cancer population to really kind of develop algorithms where we can safely treat patients with close monitoring and really maximizing GDMT and maximizing cardioprotective strategies. I think a combination of single arm studies and then hopefully randomized trials to really demonstrate that this can be done.
Yeah. The other finding that may be equally important regarding ejection fraction, clinical evidence of severity of heart failure, is the obvious finding that the patients with heart failure tend to be different than the patient without heart failure with their baseline comorbidities. They're older, and as you'd anticipate, with heart failure, they've got lots of other comorbid conditions, hypertension, diabetes, coronary disease, previous strokes, and chronic renal disease. So it's not surprising that they have a worse cardiovascular outcome. Do those comorbid factors also influence the response or the risks of anthracycline therapy as well? You certainly have adjusted for those comorbid factors very nicely, but just again, for a general cardiology person like myself, are those comorbid factors also influencing the risks of anthracyclines?
Yeah, I think in multiple studies we've seen that coronary artery disease, valvular heart disease, even low normal LVEF, higher age, are all higher BMI, are all associated with higher risk of heart failure after anthracycline treatment. I don't think we really know in patients with established cardiomyopathy, they're already a high risk group of patients to treat with anthracyclines, whether those additional risk factors modify their risk. But we know that in patients without pre-existing heart failure, that higher age, presence of diabetes, coronary artery disease, any structural heart disease increase their risk. So that's kind of what we do when we're seeing a patient that is going to be treated with anthracyclines, to try to estimate their risk and try to understand whether cardioprotection or just close monitoring is relevant. But as you say, this is an observational study, and there's a lot of considerations in the oncologist's decision about whether to give R-CHOP or mini R-CHOP, and that there's age, frailty, cardiovascular and non-cardiovascular comorbidities that are all coming into that decision. I think the study highlights that patients with pre-existing heart failure have very high one-year mortality, greater than 60%, and really trying to understand whether that can be reduced or not. And some of it, in an older patient with frailty who has a lot of comorbidities, it may not be able to. But really, I think further attempts to reduce mortality in this population, and then I think additional studies where we have more granularity about LVEF, stage of heart failure, to really also give patients further shared decision making about prognosis, I think would also be helpful.
Yeah, indeed. And do you think also there's a message here that perhaps the cardiology community, and particularly the cardio-oncologists, should be considering these cardioprotective agents that you mentioned were only used 7% of the time in patients with heart failure? Should we be getting more data on the efficacy of those therapies in patients with large B-cell lymphoma?
Yeah, proposing a trial to use liposomal doxorubicin. There's actually a small phase 3 trial in a number of phase 2 trials of using liposomal doxorubicin in place of doxorubicin in diffuse large B-cell lymphoma that showed a good lymphoma efficacy. And those were relatively small trials. So I think part of the reason they're not used is that there isn't large phase 3 trials in the lymphoma population. We do have data from metastatic breast cancer, which shows preserved oncologic efficacy and reduced heart failure, but we just need more data in this population, I think, to make oncologists comfortable using it. And so whenever I see a patient that I think is high risk and there's a question about whether we can safely give them an anthracycline or not, we always have a conversation about optimizing. My job is to optimize their cardiovascular medications and cardiovascular status as much as I can. And then there's a shared decision-making discussion with oncology, cardio-oncology, and the patient about using these other strategies, which are dexrazoxane, which is given 30 minutes prior to the doxorubicin, substituting doxorubicin with liposomal doxorubicin, or giving the doxorubicin more slowly, which may reduce the maybe cardioprotective.
Yeah, certainly sounds like a very important area where shared decision making really is important, so the patients are aware of the knowns and unknowns. Let's go back to Dr. Barac maybe for some final thoughts about where we go next with data such as these and what would be the next steps forward. Anna, thoughts?
Thank you for giving me this segue, because I believe that with this study, we always want more trials, but realistically, I think what we are ready for are very well-designed joint registries of a kind where we are getting better and better oncology treatment. And I would envision that, for example, if we want to test hypotheses, how is liposomal doxorubicin or administration of dexrazoxane prior to doxorubicin or a novel treatment regimen? I'm using that term because in oncology, we cannot extrapolate the data on dexrazoxane from breast cancer. That's a different patient population. So disease-focused, testing specific regimen in high-risk population and merging that with our think we all cardiologists listening to this podcast will recognize how different today heart failure treatment is and how differently we call things. We need to label them. Is it HFrEF? Is it HFrEF? Are the biomarkers elevated? What kind of heart failure are we dealing with? Following these patients and understanding perhaps in the real life registry embedded small trials, because I think large randomized trials in this space are going to be very difficult to conduct. But well-designed registries that will include both oncology outcomes, specific treatment intervention, and embedding the top-notch heart failure treatment, I think it will at least provide much more granular look, and I believe hope to improve patients' outcomes.
Thank you, Dr. Barac, and thank you also, Dr. Upshaw, for bringing these data forward. It's been a great discussion. I'd like to also thank our listeners for staying with us on this important topic. And so we appreciate your listening to this JAMA Cardiology podcast. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. This episode was produced by Daniel Morrow for the JAMA Network. The audio team also includes Mary Lynn Ferkalak, Audrey Furman, Lisa Harden, Hannah Park, Shelley Steffens, and Dr. Linda Brubaker, the Senior Editor of Multimedia. Thank you very much for listening.